My brief is to talk about ctDNA and answer the question, can we use it to help us start treatment earlier than we currently do, knowing that a lot of the treatments that we use today would probably work out a bit better if we could get them started when there's less cancer about. So what I'm going to cover is what ctDNA is. It's a term that's bandied about increasingly in research, and it's here to stay. And I'll work through why that is, talk about a couple of melanoma trials, one in skin melanoma and one in ocular melanoma, where we're starting to use ctDNA to direct treatment, and then talk about some of the other wider applications of the technology, including multi-cancer early detection tests, and also how we could take advantage of this technology to address cancer as a global problem, and talk briefly about a project that we're currently doing in East Africa. So ctDNA, the C and the T stand for circulating tumor. And now all cells in the body, from time to time break up, shed DNA, and some of that ends up in the circulation. So that's the circulating bit. And that's true of tumor cells as much as normal cells. And we can pick them up in the blood. Now, circulating tumor DNA is different from circulating free DNA from normal cells. With various technical changes, it tends to be a little bit smaller in terms of fragment size, and there are bits stuck onto the side of it that allow us to be confident in saying that this is DNA that's come from a tumor. We can also look for specific mutations, as I'll show in a minute or two, that we only see in tumors, so that we can be very confident when we look at this that we're detecting something that tells us that there are tumor cells about. Now, we like it for a number of reasons, but principally because if we want to do DNA studies of cancers, then normally what we do is an operation or a biopsy. A pathologist will cut it up. It'll be fixed and processed and put into a paraffin block. We then have to chop that block up. A pathologist then identifies which bit of the block has cancer cells in it and draws a little ring around it. And then somebody comes along and scrapes off the bit that's being marked, sucks the DNA out of that, and then we have our diagnostic test. Now, circulating tumor DNA gets around an awful lot of that. We can collect it in a vacuum tube. It's a special tube. It's different from the normal tubes that we use for blood tests, but it allows us to preserve the DNA. And a couple of those tubes costs about 15 quid, and you can pop them in the post without any extra precautions other than a bit of padding to make sure they don't break in transit, and you can send them at normal temperatures to a lab to be processed. And as long as it gets there within 3 or 4 days, then it'll be a faithful representation of what you took out from the patient on the day that you did. And so we can bypass all of these steps and look at the DNA that's circulating and draw some conclusions from that. So it's got fantastic potential to cut out a whole bunch of stuff that's expensive and time-consuming, and also, because it's blood, we can come back and do it again and again, and so we can track things over time. So that's why everybody's very excited about it. And so these small fragments of DNA are in the blood, and what we can do is we can look at just the quantity of it, if we want to, and there are tests out there now that do that just say how much ctDNA there is. But the other thing that we can do increasingly is look at the quality and what makes it up. So we can look for mutations in the DNA, and so if this is normal tumor, and if this is normal DNA, and then this is tumor DNA, looking at the same point, you can see that you've got a different base pairing there. So we can look at things like that and detect the proportion of the circulating DNA that has a mutation versus the proportion that's normal. So this is the technical term for this is variant allele frequency, or VAF. And we can also look at whether there are changes like methylation there are a number of changes where molecules are bolted onto the side of DNA, because if you think of DNA as our genetic code, then there also needs to be a code book that goes along with that, that says, as well as translating this code, this bit's important, you can ignore that bit, and so forth. And so there are various bolt-ons that we can look at. And in particular, we know that these bolt-ons to DNA are very, very different in cancer from in normal cells. So most of the technology looks at these bolt-ons like methylation groups and various other elations that can happen to DNA to tell us what's going on. So that's the basis of the technology. And then the other thing that we like about it is that if you buy the right collection of very, very expensive machines, it can be super automated. So the weakness of that pathway I showed on the right-hand side a couple of slides ago is that there's an awful lot of human beings involved in looking at things and making moderately subjective judgments about this bit matters, I'm going to take the DNA from that bit, and so forth. And by and large, that's great. The NHS is full of highly trained people who are very good at doing this. But it turns out they're slightly rubbish at doing this on a Friday afternoon compared with a Tuesday morning, and so forth. Whereas these machines just sort of crank on and do it again and again and again faithfully. And the other thing is that these machines are automatic. They don't go on strike, except when they break down. And they can run 24 hours a day. So you can get an awful lot done automatically using the DNA. And then the other thing is that a lot of the interpretation, once these machines spit out the sequences, is done using computer power, which can be anywhere in the world. Now, that doesn't matter so much to us here in the UK, where we've got lots of that computing power and lots of people to do the interpretation. But you'll see in a minute how important that could be in other situations, like in East Africa. So how are we using this in the melanoma field? Well, apologies for talking about something that isn't ocular melanoma, but is skin melanoma. But you'll see in a minute why I mention it, because the trial that I'm going to spend most time talking about piggybacks off the back of this, or at least that's what we intended at the time that we set up our trial for ocular melanoma. So detection was the first attempt to look at this in a systematic way in melanoma. And the reason that we did it is that in skin melanoma and across all of cancer, if you've got stage 4 disease where the surgeons can't take it out, you get drug treatment or systemic therapy. If you've got a high-risk situation where the lymph glands are involved, then the surgeons will take out all of the melanoma. We know there's a big risk of it coming back, and we'll give treatment, usually immunotherapy, or if you've got a BRAF mutation, BRAF-MEK inhibitors, to try and limit that risk. But actually, only a very small proportion of people with skin melanoma are in this pointy bit of the triangle, because the vast majority of people have quite thin things that come off, and it's quite rare for these to come back and cause serious illness. But the problem is that there's so many of these people that nearly a third of deaths come from people in whom we would traditionally say this is a low risk, we don't need anything done other than the surgery. So what this trial said was actually, well, if we apply ctDNA in this space, maybe we can pick out some of these so-called low-risk people and identify them as needing treatment, even when we can't see anything on the scan. And then if we apply that treatment when we can't see anything on the scan, we think it'll work better than if we wait for lumps that are big and full of different types of cells, some of which may resist the treatment. So our plan was to get over 1,000 people with a bunch of mutations that are specific to melanoma. And if we detected them in the blood over a 3-year period, actually I think we then decided to extend it out to 5, we would either do what we normally do, which is nothing, and wait to see lumps on a scan to decide to start treatment, or we would start immunotherapy. And this was going to be a randomization, so the lab would know who was positive, and for these people, we would just keep that to ourselves, and for these people, we would let the doctors looking after the patient know, and then have that discussion with the patient about starting treatment on the basis of a blood test, not a scan. And the reason that melanoma is very attractive for this, and this applies to ocular melanoma, as I'll show in a minute, as much as to skin melanoma, is that we know that the vast majority, if this is all of melanoma, then well over 3/4 of it are driven by highly repeatable mutations in genes that we can go looking for in the ctDNA. So we don't just have to try and quantify ctDNA, we can go, well, okay, well, if we look for this set of mutations, then that'll pick things up in 3/4 of people. But, and obviously we've got the tumor that the surgeons took out, so we can know what we're looking for as well in each individual patient. Now that's an important difference from when we get to ocular melanoma, which I'll talk about in a minute. So over many years, in a study led by Pippa Corrie, we were able to look at ctDNA in people who'd had scans after surgery and to see if we could see the ctDNA and see what the implications of that were in a clinical trial that we'd run in which the drug we used, bevacizumab, turned out not to be effective. So it didn't matter whether you were assigned treatment or not. And what that showed is that if we could see ctDNA, then the chances of the melanoma being detected clinically, and these are two examples from different groups in Manchester and Melbourne, were very, very much higher than if we couldn't see the ctDNA. And so that gave us reassurance that if we use this as a test, that the risks of us throwing immunotherapy at people who weren't going to run into trouble anytime soon wasn't there. So much for cutaneous disease, but this is ocumel, and what are we doing in ocular melanoma? Well, we're doing the same thing, but obviously we're constrained because nivolumab, or indeed nivo and ipi together, aren't brilliant treatments. And so the first thing is, if you're going to go looking for trouble by doing a ctDNA test, you better be able to do something about that trouble when you find it, or at least have an idea of what you might do. So we built this around tebentafusp. But tebentafusp, as all of you will know, is what's called a bispecific immunotherapy. It sees GP100, a peptide that's very commonly, almost always overexpressed in ocular melanoma, when it's presented by the immune system. Now, that's a huge advantage for treatment because it means that TEBI can work where there's only a very, very small number of targets like this on the immune cell, but it's also a disadvantage because you've got to have the right immune system for TEBI to be able to see the GP100 being shown to it on the cancer cell. This is what's called the HLA-0201 tissue type, and that's about 40% of us of European descent. So this is a study that can only be used in the 40% of people who have that tissue type. Not because of anything to do with ctDNA, but because if we do find it and then we want to do something about it, then only in 40% have we got the means to do that. So TEBI, you'll remember, was invented by a company called Immunocore, which span out of the University of Oxford. And so we did the phase 1 trial, the first study of this drug in Oxford. And actually, Jeff Evans, who was talking just now, was one of the other main investigators in this study. And initially, we thought that this was going to be for skin melanoma because it's commonest. But we saw very early on that in uveal melanoma, we saw spectacular responses, and in a good proportion of people, and certainly as often as we saw them in skin melanoma. And over the course of the phase 1 study, we became increasingly interested in what could be achieved with this drug, because we saw a couple of other interesting things. So, for example, if you think that Nivo and Pembro don't work terribly well in ocular melanoma, we saw a couple of people in whom we gave this, and then they went on to have Nivo and Pembro and had really good responses to those drugs. So a first suggestion that this might prime something that other immune therapies could then go on to benefit from. So as you'll all be aware, this then turned into a very large phase 3 study, which showed that you could double the survival of people with metastatic ocular melanoma by giving tebentafusp. And then, perhaps in distinction to what we saw in our clinical trial, the number of people whose tumours shrank or achieved what we call a resist response, which is quite a high bar, the tumour's got to shrink by about a third to trigger that, was really very small. So only about 10% of people having tebentafusp got that significant shrinkage of all their tumours, even though we think about 40 to 50% of people were getting a benefit. But if we looked at any tumour shrinkage, instead of that very high bar of shrinking by a third, then it was more like the 40% that we think are benefiting saw some form of tumour shrinkage. But what this told us is that the size of the lumps isn't necessarily a good indicator of what's happening in them when you're looking at them on a scan. And why do I belabor that point? Well, it turns out that if you looked at the circulating tumour DNA, which we did in a subset of people in this trial, it's much better at telling us what's going on. So you've got 3 lines here. They've called it marker, but the marker is circulating tumour DNA. So in the black line, the marker's gone, so they had circulating tumour DNA when they started treatment, and it all disappeared during the course of treatment. In the yellow, in the green line here, you've got the marker was there, but it decreased during the course of treatment, and then the red line, the marker was there, but it went up. And that was true for the majority of people. So this is a set of just under 40 patients, and for half of those, 22 of them, the marker went up. But if you look at the went down or went away completely, you can start to see how if we'd had more patients, this would have mirrored much more closely that line of separation that we saw in terms of how long people lived. And what we would see there is that and so where you see a little nick on these lines, this is somebody in whom nothing has happened, and we've carried on following them for several months, up to a couple of years. So what this is telling us is that if the ctDNA goes down, that's a sign of benefit from treatment. Now, there are all sorts of caveats with this because it's a small sample size and all the rest of it. But that encouraged us to design the trial that we've got running now across several centres in the UK, not as many as we'd like. So we thought there were 2 things that we wanted to look at. One is that if we could identify molecular relapse by using ctDNA, we could get better responses for longer because we'd be treating a very small amount of disease before it had a chance to grow. So that was the main hypothesis. We understand, and this is by extrapolation from all sorts of different cancers, that if we use immunotherapy early, we seem to get the best results, by and large. When we use new agents, if we use them, if we're going to give them to everybody, which is what adjuvant treatment means, after surgery you identify a risk based upon what you've seen at the operation, then you treat everybody who falls into a high-risk category. That's becoming almost impossible for us because if you can't select people more effectively, then we have too many people to treat with too much toxicity and not enough time in which to do it. So what we thought was, could we use ctDNA to choose whom to treat them earlier, and would we get better responses as a result of that? Now, obviously, there's all sorts of things we don't understand. This concept of molecular relapse disease, now the hematologists have been using this for years and years with their drugs and their types of cancer, but that's super easy because their tumor is in the blood. So studying the blood tells you everything you need to know about the tumor, give or take. That's not true for us where the tumour is in the liver or the lung or somewhere like that and not circulating in the blood generally. Obviously, we don't know if we clear the molecular mark, does that actually mean anything in real life? Well, obviously, the phase 3 trial suggests it does, but as part of this study, we're going to have to check that out. And then we've never tried before to look at a large population of people with melanoma and use molecular marks to decide treatment. Obviously, that's true only insofar as the detection study in skin melanoma hadn't started at the time that we set this up. So, first thing you've got to do is to have a test that you can rely on. I'm very fortunate in Oxford that we've got an experimental molecular diagnostics centre that's really very good at developing these tests. So, we write the protocol, the idea that we want to use ctDNA to go and look for ocular melanoma in people, and then they can turn that into a reality, including to all sorts of really very tedious standards, but really very important, so that when they issue a test result, we can rely on it, and we can look a patient in the eye and says, this is real, this is not some figment of my imagination, this tells us what to do next. So that's a process that took them about 6 months, building on work that Immunocore had done as part of their trial with a company in the US. And the reason we were able to do it is that in ocular melanoma, a bit like skin melanoma, there are 3 genes, GNA11, GNAQ, and SF3B1, mutations in which pretty much give you are present in pretty much every single type of ocular melanoma. Now, there are others, so we don't just stop there. We do a bunch of others as well. And in fact, we developed a panel for both skin melanoma and ocular melanoma to use in the same situation. So once the lab had this up and running, we were in a position to open this study. And we've set it up in 3 phases. So the first thing we do is that when we've got people, and in this case, for ocular melanoma, this is people who've had their tumour excised, and it's been deemed to be a high-risk cancer in the sense of it's a high risk of coming back. And you will know that that's done on the basis of what it looks like under the microscope, what the cytogenetics show, and where it is, and so forth. So if the clinical team said that this was a high-risk cancer, then the first thing we do is pre-screening. We would send a sample of blood to the tissue typing lab. Unfortunately, every major hospital has a tissue typing lab as they use it to match organs for transplants. And they'll tell us whether you've got this HLA-A*02:01 tissue type that means that tebentafusp is a goer as a treatment if you develop further problems. So what we aim to do is to look at 850 people, and we said from 50 centres who are part of the detection study as a means of doing that. Unfortunately, because the detection study has foundered almost as soon as it got off the ground, because there are important changes in the treatment of skin melanoma, it means we're actually going it alone, so we're a bit slower than we wanted to be. But the idea is to recruit 850 people. Half of those, or over half of those, will drop out immediately as having the wrong tissue type, so that if we found something, we wouldn't then be able to do anything about it. And then we're going to follow them up for 12 months and use the molecular test every 3 months to look for trouble. And then up to 50 people would be identified as having this molecular relapse disease, and we would treat them with tebentafusp at 10 treating centres in the UK in order to see, first of all, whether we could make the ctDNA go away. And then to ask questions about, well, if we made it go away, did we then not see anything on scans? And was there a difference in how long it took for something to show up on the scan if we made it go away versus not under treatment? So that's the idea. We made a few changes since the study started. As I said, we can't piggyback off the detection study anymore, so we're going it alone. As of this week, I think we're just about, Sheffield, I think, had the site initiation visit this week, so we're just about up to about 10 centres at the moment, 4 of them able to give treatment. So if you do get a positive test, you have to move around a bit to get the treatment at the moment. We've not been helped by the fact that TEBI hasn't been hasn't sorted itself out with NICE, so it's not being used as widely as we would like, so that we could just slip this in along with standard approaches to treatment. So that whole thing has made things go a little bit slower. So again, we estimated that we would find molecular relapse disease in about 10% of people during the course of the year. It's too early to know whether that's true. So where are we at the moment? Well, we're open to recruitment. We've got nearly 100 people in the trial. The vast majority of those are with ocular melanoma, although we allow cutaneous melanoma in as well. And we had our first molecular relapse disease at the beginning of the month. And that individual is starting treatment next week. So it's having an impact upon patients. Obviously, we don't know what that impact means. Now, the other thing we want to check as part of this, but this is research, you can't hang anything on this, it'll just be a suggestion, is, remember I said if we treat early when we can't see anything on the scan, we should get better results. Well, how do you tell if there's nothing to measure on the scan? Well, in the phase 1 trial, we looked at a number of markers in the blood that correlated with good outcomes, both in terms of cytokines, of which CXCL10 is an example, and in terms of cell types. And so one of the things we'll do is to collect samples so that we can look at the same things in people who don't have visible tumor on scans that we did in the early trials and say, well, can we see the same pattern? And is it different is it qualitatively different in a way that would lead us to believe that our hypothesis was correct, that we were getting better treatment? Now that's a slightly tricky thing to work out, but it'll give us a direction of travel if nothing else. So that's where we are using ctDNA to take an exciting new treatment that we know works in ocular melanoma and try and make it better by using it earlier. Now I'm going to shift tack for the last 5-10 minutes of my talk and talk more generally about how we can use the same technology right across cancer treatment. And so what I'm going to talk about is a collaboration with a company called Grail that's based in the US. And just to be absolutely clear, they gave me, through the University of Oxford, 4 million quid to do a study. So you probably can't believe a word I say. If they'd given it to me, maybe not. But as I say, they gave it to the university for us to do a study. And so what I'm going to tell you is a little bit about that study. So why do we care about ctDNA in people who we haven't yet diagnosed cancer? So if we look at how cancers are diagnosed in the UK, then if you've got a symptom, you go to your GP with a symptom that might be cancer, then we have this system called the 2-week wait pathway. You're supposed to be sent rapidly into the system to have a test or see a consultant that will tell you whether you've got cancer or not. And that's how the majority, about 4 in every 10 cancers, are diagnosed. It's a little bit of a clunky system. It's got a couple of problems. One is that 95 to 96% of people we put into that system don't have cancer. So there's an awful lot of work going on in order to find 4 to 5% of people who have cancer. And the other is that for various reasons, we don't all go to the GP and fit into that pathway and all the rest of it. So about a quarter of cancers are diagnosed in the emergency department. And those people who are diagnosed in the emergency department don't do well with treatment, because usually that means it's come along late, it's harder to treat, they're less well, and therefore there are fewer things that we can do without damaging them beyond repair. So, and if we then translate this into stages of cancer, then we can see that there's lots of cancers where often we only pick them up at stage 4. And it turns out that melanoma, again, dominated by skin, is actually one of the best ones because it starts as something on the skin surface, so we do quite well. But there are other tumor types where we manifestly do very badly, like pancreatic cancer here, second from the right. And we only find it when usually it's beyond effective treatment. So what Grail have developed over the years is a test not to look at one type of cancer, like the test that we developed for the TEBI-MRD study, but something that would look at multiple cancers, so a multi-cancer early detection test. It's based on circulating tumor DNA, and it's actually based upon those little marks that get attached to the DNA to tell which bits are important and need to be translated versus the ones that are less important, because it turns out that that is much more different than the DNA itself for most cancers. Now, so this is called epigenetic information, and so most of the tests in development make use of that, if not exclusively, and there's a large part of the test. Now, we used the GRAIL test because it was ready to be used at scale. There's another study going on with 100,000 people in it, and they're already selling it as a product in the United States, so it was ready to be tested. There are dozens of other technologies out there, but they weren't quite ready for that scale of evaluation, so we didn't use them. And what we're trying to do is to interfere in the diagnostic pathway. There's a trial called Gallery, which looks at people who don't have symptoms, so it's effectively using it as a screening test. What we were doing is looking at people who have symptoms and saying, well, how will the test perform in that situation? So there are a number of issues with this approach in that, when you do a big trial like this, and this was for 6,000 people across 40 hospitals in the UK, we're very, very good at reaching motivated people who already access healthcare pretty well and are savvy about their bodies and so forth. And they're not the people we necessarily want to reach because they're probably making good use of the 2-week wait pathway, and so the chance to make a big difference is limited. So one of the questions is, well, how do you get this blood test to people who currently don't go and see their doctor, ignore their symptoms and so forth, because they're likely to ignore your blood test just as well. Obviously, there's also worry that if somebody has a blood test, and no blood test is going to be perfect, they'll go, okay, well, the blood test is negative, I haven't got cancer, and then they get a symptom that they should do something about the next week, and they do nothing. And then there's the other problem, which is that you get a positive test, and then how do you clear it? If you do a scan after a positive blood test and there's nothing on it, does that mean that the blood test was wrong, or does that mean that you've got to keep worrying about it? And have you made a whole bunch of people worried who haven't got cancer? So there's all sorts of issues like that around this sort of test. And so with certain trepidation, there's this big study called NHS Gallery, which is looking at people who are well. I think it's over the age of 50. I'm not directly involved in it. And so it's looking at 100,000 people to see whether using this test in people who have no symptoms is a way of picking up early cancers. It's fully recruited, and I think the first results are due to come out next year, and the final results a year or so after that. What we did was to look at 6,000 people who were already going to be referred in to see whether they had cancer, and compare the performance of the test with the standard investigations for cancer. We recruited 6,000 people. We could look at the test result in about 5,500 of those because there was a certain amount of technical failure. And not everybody went through and had all of the tests against which to compare them in the standard NHS investigation. We found 300 people with cancer across that cohort, just over 300. So about 6% of the people in whom we had both a blood test result and an NHS test result. And the test was accurate about 70% of the time. What it did was if you had a positive test, it turned your base rate of having a cancer from about 6 and a bit percent up to about 75%. And it made if you had a negative test, it meant that your risk of having a cancer diagnosed was about 2%. So it cut it down by about a third. So what that showed us is that whilst the test was useful, we couldn't possibly use it in this situation because if you're missing a large number of the cancers, that's not very useful. And 2% risk of cancer, still 1 in 50, that's still quite high. So we would have to refine the test, to tune the test in order to get better information. And certainly in order to use the blood test to say you don't have to have a scan or you don't have to have a scope, we would need a better test than the one that we had currently. We did identify a couple of situations with very vague symptoms where we thought we might be able to use the test. So if you've got tummy ache and a bit of weight loss, a negative test would take your risk of having cancer down to below 1%. So thinking that we're close to the ballpark where you might be able to use that test to say, no, you don't need further investigations. So that's something that we're going to develop further over time. So for the last couple of minutes, I just want to talk about a totally different approach. And this comes back to the slide, one of the slides I showed earliest, which is about how we use this application, how we use this sort of technology in places with less developed health systems. So what we're interested in doing here, and this is in East Africa, is to look at taking a blood test as a means of diagnosing cancer, full stop. And what we focused on here, my colleague Anna Shu is looking at a type of lymphoma, Burkitt's lymphoma, that's endemic in East Africa, is driven by a virus called Epstein-Barr virus, and that you can look for ctDNA as a means of making that diagnosis. Now, what's exciting about this is this is a country with very few pathologists, very few people doing the diagnostic part of healthcare. And if you remember that slide I showed at the beginning where you had to sort of cut it out, somebody had to look at it, put it in paraffin, somebody else had to look at it, you had to make a slide, all of that is super, super difficult. So what's attractive about this is that you can take blood, and you can do that almost anywhere in the country. You can then send that blood in the post or by courier, whatever the transport system, to a centralized location, in this case Kinshasa or Dar es Salaam in Uganda and Tanzania. And then you can analyze it there using those machines because they've got skilled people who can use those machines that I showed you pictures of. And then they can do the bioinformatics, the technical stuff, but because it's all done on the cloud, we can help with that as well using computer power here in the UK, or if it's in the cloud, who knows where it is, in order to make a diagnosis. And so this is, the aim with this is to develop something that, this isn't white savior mode going into East Africa. This is about developing something that's sustainable by Tanzanian and Ugandan doctors that can then lead to health benefits for the population and that doesn't need us in the end. And one of the reasons that we can do this is that a whole lot of sequencing capability was put into these countries as part of the response to COVID, because like us, they needed to track that in their population. And obviously, as that has become less important, we've been able to take some of that sequencing capability and apply it to this technology. And we've had strong support politically from the ministries of health there. We've set up a social enterprise so that we can sustain this beyond the lifetime of the grant we got from the National Institute for Health Research here for global health. And most importantly, the treatments for this cancer are really quite simple to give. So it comes back to what I said about TB-MRD. Don't go looking for trouble unless you can do something about it. And that's one of the reasons that we picked Burkitt's lymphoma for this, because it responds spectacularly well to cheap, old-style chemotherapy. And so what you've got here is a young lad with a really massive facial tumor there, which comes back to something near normal within a month of starting treatment. So you can have a fantastic impact, and you've cut out the problem, which is the problem wasn't giving treatment to people, the problem wasn't finding people, the problem was making the diagnosis to link the treatment to the cases that you found. And using simple blood-based technology to do that is a really fantastic step forward that hopefully will mean that many, many more cancers and indeed non-cancer diseases can start to be diagnosed in a different way without the need for lots and lots of pathologists and specialist technical staff in order to do that. So I just want to sum up by saying, ctDNA is, I think, has a huge potential to disrupt how we currently practice medicine in a really good way, because I think it gives us lots of new opportunities, as well as finding cancers as they come back or for the first time. We can also use it to monitor the effects of treatment. Others have shown that if you start chemotherapy for breast cancer, ctDNA should crash really within 2 or 3 weeks Otherwise, that's a sign that that chemotherapy is not going to work. So you can find that out within 2 to 3 weeks rather than within 2 to 3 months, as we currently have to. You know, the big problem here is that technology is moving really, really fast. So you could always, anytime you want to do something to field test it, you could be forgiven for saying, well, I'll just wait another year because there'll be an even better test coming along. But actually the challenge there is to say, well, actually, you can't do that. You have to go and start with what you've got and work out how it works. And then the other problem we have is, yes, it's fantastically compelling, it's really interesting, but as with all cool new technology, somebody somewhere is going to oversell it. And then somebody else somewhere is going to get a bit fed up that it doesn't deliver on the promise of that overselling. And then it'll take 5 years to recover from that and find its true level. So we have to be a little bit cautious, and that's why proper clinical trials, examples of which I've shown this afternoon, are absolutely necessary. This isn't something that we can just rush out and do. It needs to be done systematically and well so that we use it in the right way. So I think that was all I wanted to say. I do apologize for having sent the old slides, but we'll correct that. And hopefully it'll make a little bit more sense if you go and look at it again in a day or two.